good evening. Once again, we are good evening in Pakistan, good morning in America, and um I'm so thankful to Professor Mallory Shawn for uh, sparing his time to talk to us on the endoscopic ultrasound. I know he's a great expert in the endoscopic ultrasound. He's a professor of medicine at University of Minnesota. Dr. Mustafa Rai, our old friend, is going to introduce him in detail. And today we are going to spend 50 minutes on endoscopic ultrasound and then another 10 minutes on question answer. I'm sure that you're going to enjoy this talk immensely. And over to you, Mustafa.
Thank you, Professor Gas, and good evening to everybody in Pakistan. Assalamu alaikum, and good morning here in the US and parts of the UK and other countries. So it's a pleasure to introduce Professor Shawn Mallery. He's a dear friend and a colleague from Minnesota when I was there. Dr. Mallery completed his medical education in Chicago and moved to Minneapolis, Minnesota for his residency and fellowship training, and then went to Harvard for his endoscopic ultrasound ERCP training. And his interest really was sort of developed in EUS very early when the field was still finding its role in the management of patients. He trained with Dr. Bill Brugge, who's one of the forefathers of EUS in the US. And Shawn is essentially a sort of a one step below in terms of timing, but is truly a world expert on EUS, has over 32 years of sort of experience doing this now. So when most people didn't even know that EUS was around, he was already practicing it. He is one of the finest people that I know, one of the most humble and kind gentlemen that I know, who has always been extremely generous to me and a great teacher and a mentor. His talk today is focused on diagnostic aspects, but he is also a very, very proficient therapeutic endosonographer. And some of the sort of memories that I have of working with Shawn during my fellowship, I remember that there was a case that Shawn said to me, "Okay, now show me the liver." And I was scanning the liver. I kept scanning it, looking at it. I thought maybe there was a lesion that I had missed, so I kept looking at it. And after about 3 seconds, there's this nerve. So 3 minutes almost. I'm looking, nothing from the back, and I'm getting nervous that I'm missing something. So I turn around and I say, "Is there anything else you would like to see?" And Shawn very calmly said to me, "That's the spleen. Now you can show me the liver." So I remember that one of the strengths that Shawn has is his patience, and his sort of teaching style was very, very patient and kind. And the other thing was how he correlated CT anatomy to EUS and was able to describe things. So I think our audience will really enjoy listening to Shawn, and hopefully someday we can have Shawn even visit Pakistan and actually demonstrate EUS the way he does it. So without further delay, I'd like to welcome you, Shawn, to this panel and look forward to listening to your talk.
Thank you, Mustafa. It was a pleasure working with Mustafa for several years. He is likewise, I would say he's one of the most patient, thoughtful, skilled endosonographers I've ever worked with, and it's been great to see your career blossom. I'd like to thank Dr. Diaz for inviting me, and I would tell you the only disadvantage of giving this talk to a group of physicians in Pakistan is that I don't get to be in Pakistan at the time I'm giving the talk. And it would be a pleasure to come visit sometime. I would really enjoy that. So Mustafa had contacted me about giving a talk, and I know you're having a series of lectures, and so we tried to ask about what the things would be for diagnostic EUS that I could review that maybe haven't been focused on, or things that he specifically asked me to focus on. So I'll talk a little bit briefly about anatomy. I know you've had doctors speak on EUS anatomy, and many of you are familiar with it, but I have a couple of slides that I think may be helpful conceptually, particularly to people who don't do a lot of EUS. And then I'll review a videotape that I have. It's a little bit old, but I've looked at it a couple of times. I think it comes across clearly enough on the video that basically shows in about 6 minutes how to do a complete EUS exam, and just talk about how I go through the exam. Then we'll focus on lumps, bumps, sticks, folds, things that you see endoscopically that may need further evaluation, and a brief talk on complications, because I don't think anyone's discussed that yet to you so far. So I did want to briefly review where we are in the world, where I live right now in Minnesota. So it's where that asterisk is in the upper left-hand slide. In the state of Minnesota, it's a city that's on a river. Minneapolis was developed because it was on the river, and it was at a place where there were waterfalls in the river, and so the mills for the grain processing were all based in Minneapolis. That's at the origin of the Mississippi River, and so historically much of the grain in the United States would filter through Minneapolis, get processed, and then the flour would ship down the Mississippi River into the Gulf of Mexico and go to the world. North of us is really the more beautiful part of the state. I just wanted to show this. I was not born and raised in Minnesota. I was born and raised in Chicago, and there's so much natural wonder here. I just think it's one of the more beautiful places in the country, and a place that people tend not to go visit. This is a lighthouse on Lake Superior, which we are right in the middle. We are about as centrally located in North America as you can be, but we do have a very large lake, Lake Superior. So parts of us feel like we can live on an ocean here. The big event we have here is the Minnesota State Fair, which is the second largest fair in the United States. And you can see on the right-hand side how crowded it can be at times. They get up to 150,000 people a day at this fair, which is it surpasses my tolerance for crowds. And if you need to get away, this is our national park at the north borders of Minnesota, the border of Canada, called the Boundary Waters. There are no motorized vehicles allowed in here. The only way to get into the park is by canoe. People canoe in and then camp on designated campsites. It really is one of the wonders of our country, and it's a shame to me that more people don't go visit this. So I'm sure you're familiar with typical EUS endoscopic design. There's radial endoscopes and linear endoscopes. And just to review the difference between the two, this would be a view of the pancreas with a radial endoscope. Again, the imaging plane is in a circular pattern that is perpendicular to the long axis of the endoscope. So the pancreas looks fairly similar to the appearance on a CT scan. The linear image would be as though you cut this imaging plane with a knife going down the middle of it, and then flip the knife on edge. And then you see the pancreas in cross section with the pancreatic duct as a small circle cut in cross section. The difference between these two technologies is most relevant when it comes to doing needle biopsy. And this diagram kind of represents what it would look like imaging a banana with a radial endoscope. And you can see that with the radial endoscope, you just see the banana in cross section. And the only place that you would see a needle advancing through the imaging plane would be a small dot. And I will tell you that when I started doing EUS, Olympus only made radial devices, Pentax only made linear devices. I worked at 2 hospitals, one only had radial, one only had linear. And so we spent quite a bit of time trying to figure out ways to do needle biopsies with radial scopes, but it was basically impossible. This is what a linear echo endoscope would image if it was looking at the banana. And you can see the main advantage with this again is that you can see the entire length of the needle within the ultrasound plane. So I'll show a couple of basic images for radial anatomy. I know you're fairly familiar with this, and just to tie our fair frame or our state fair theme into this. This is how a CT scan correlates with where the echo endoscope would be positioned in the esophagus, doing radial image of the mid-mediastinum. And you can see the corresponding images on the left with the CT. I don't know if you can see my arrow, but the azygos arch here on the CT scan to the left, the aortic arch to the right, and you can see that you really don't see much beyond that area because of air. We can't see through lung and air with ultrasound. And then the trachea is just seen as this area of artifact with reverberating white bands. As we go further down, again, we see the aorta, the azygos vein, the thoracic duct, which we really don't see with the linear endoscope for some reason, and then the left atrium in front. And we're really kind of focused just on this small area in that circle on the left with our ultrasound transducer. Once we get down to the pancreas, this is a corresponding CT image to a kind of a classic radial image of the pancreas. And again, you can see the pancreatic duct elongated, portal confluence in cross section with the splenic vein joining it, and then the superior mesenteric artery, which is in a little notch below the golf club shaped portal confluence. Celiac trunk is described as kind of a whale's tail, and there you can see where our scope would be and on a CT scan, and kind of a corresponding CT image of this view. And so radial imaging very well correlates with CT imaging, and I think in the beginning is much easier for people to acquire understanding and knowledge of radial anatomy until you get into the duodenum. When you get into the duodenum, suddenly the ultrasound transducer tilts and rotates out of the imaging plane of a CT, and instead of corresponding very well to the CT, you almost have to imagine cutting through it like I did on that previous cartoon, cutting through the CT imaging and then rotating it up on edge. And the ultrasound imaging plane would be a circle that you're seeing on edge there on that CT scan. And if you were to rotate that into a circular image, this is what the ultrasound image would see. And again, you can see the portal vein heading posterior to the duodenum, which would head up into the liver, changes caliber when it turns into the superior mesenteric vein, and then the superior mesenteric artery comes and joins it. Common bile duct is very close to that, just small little adjustments in the rotation of the end of your transducer will visualize the common bile duct. And again, this is, as we all know, a very good technology for looking at the entire length of the common bile duct, screening for bile duct stones, looking for obstructive processes in the bile duct. Now, I'll move on to some similar images in representative locations for linear anatomy, but then again, I'll show a video to demonstrate this. Again, this is what we see in the aortic arch. To me, it looks like a skull. You can see the pulmonary artery or left branch of the pulmonary artery, the aortic arch. Commonly, it's, I don't know if you can see my arrow, but the area, if you take the closest approach between the pulmonary artery and the aortic arch and draw a line between it, the space below that where you would have the nose on the skull is the AP window, and the area above that closest to the transducer is level 4L when we're doing lymph node staging. It's commonly misreferred to as the AP window, but the AP window is the nose on the skull. This is what the aorta and celiac trunk would look like with the linear scope. And again, this is a useful image to obtain when we're doing celiac neurolysis. But again, it's I try finding representative CT scan images, and even with coronal and sagittal sections, it's hard to find CTs that show it lining up in this way, because typically it's a little bit rotated out of plane on a sagittal CT. Pancreatic body, again, we demonstrated before in cross section. Pancreatic head with the transducer in the duodenum, and you can often see a slightly hypoechoic ventral onlage and a slightly brighter dorsal pancreas. With the pancreatic duct in this view, you can see the pancreatic duct crossing between the ventral and dorsal border, thus excluding pancreas divissum. But again, to demonstrate this better, again, I know this is a little bit of an old video, but I think this is an example of how you can do a complete EUS exam relatively quickly. I think some centers in our country have a tendency to do very focused EUS exams. If there's a pancreas mass, they may only go look at the pancreas and get a biopsy, and I think that's a disservice to the patient. It's almost like getting a CT scan of the abdomen, but only looking at the liver. I think when you're there and you have access to the anatomy in the upper abdomen and the mediastinum, you should be looking at all of it. I can think of numerous cases where I found unsuspected findings. I found pulmonary emboli. Incidentally, I found aortic valve vegetations. I think you're there, you should look at it, and it can be very helpful for the patient. So hopefully this video we run, this is with the scope transition or positioned just at the major papilla. This is the smaller of these two structures is the pancreatic duct, the larger is the bile duct. And again, just slightly rotating counterclockwise here and pulling back into the bulb, I can follow that bile duct as it goes up into the liver. and we'll see it just stay in view. The more I torque, eventually the liver will come into view here. You can see the cystic duct branching off of that, and there I have liver. And as I come back, again, you see the cystic duct joining the bile duct coming down to major papilla. And then we'll pick up the main pancreatic duct, which you see crossing anterior to the portal vein at the right hand of the image. This is superior mesenteric vein, superior mesenteric artery, and portal vein. Now I've pulled back slightly into the pylorus, and you see the vessel is a trifurcating vessel. The SMV is to the left, splenic vein to the right, and portal vein in the middle. Torquing further clockwise and coming back into the stomach, I follow the pancreas, which is a salt and pepper type position, organ directly under the transducer. And we follow that. I can follow the pancreatic duct and the pancreatic body to the tail. Here is the spleen, not the liver, Mustafa. And I don't see any bile ducts in that spleen, so that confirms the organ. We follow, this is the left kidney. We can look at some of the left kidney. I personally don't feel completely comfortable assessing for renal disease with this, but I have on occasion biopsied renal cell carcinomas when we need to. And then as we follow the superior pole of the kidney towards the right-hand side of the image, we can see the left adrenal, which is this very thin black line just below the pancreas. We can scan back and forth over the adrenal gland to look for lesions. Then I have, coming back more towards the midline, we'll get to aorta. This is the aorta, and we'll see as we rotate on that, the branches coming off there, that's the celiac trunk. And there's the superior mesenteric artery, which just came into view for a second. I think I get back on that here in just a sec. Left adrenal. This is splenic artery, and we follow the splenic artery into the spleen, torque back, follow the splenic artery back. We should be able to follow that back to the celiac trunk here. That's the celiac trunk. All right. The left gastric artery comes off the celiac trunk and comes back towards the right-hand side of the image, which we intermittently are scanning over in this image. Now I'm following the celiac trunk the opposite direction, and it will split. Instead of following to the spleen, we follow it towards the liver. Here we're getting some air artifact, which we'll have to suction that out. And then again, this is hepatic artery. So if we go back to celiac trunk, come to the midline, and then torque counterclockwise towards the patient's right, then we have the common hepatic artery, and we can follow that up into the liver. Again, sorry, I don't know why this is running so jerky. I apologize for that. But now we're back to the splenic vein, which is the larger of those two vessels, splenic vein to spleen, splenic vein going counterclockwise towards the patient's right. And again, we'll join the superior mesenteric vein, turn into the portal vein, which is that larger vessel, and go up into the liver here. Now, if we come back more, if we're looking at the liver, we can see several vessels within the liver. This is the porta hepatis, that bright tissue in the center is porta hepatis with the portal vein. That white line here going towards the left-hand side of the image is the falciform ligament, and hepatic vein there coursing through the liver. We can follow the hepatic veins superiorly towards the junction of the inferior vena cava and hepatic vein. That's aorta. Go again slightly counterclockwise from aorta towards the patient's right. That's the IVC, with a hepatic vein coming in at an oblique angle, joining the IVC. And as we withdraw a little bit more, we'll cross across the diaphragm, follow the IVC into the right atrium. So that's the right atrium, and then that's the left atrium. And as we rotate, that's your aortic valve, deep to the left atrium. And then in a second here, we'll focus on the aorta, come back. That's the azygous vein, a smaller vessel. We'll show with Doppler. There's an azygous vein there. And then rotate back to the left atrium, aorta, just by rotating 360 degrees here across the mediastinum. And that's aorta. As we pull back and withdraw, we can see both the azygous vein and the aorta end bluntly with a rounded end on them, and that is the arch of the azygous vein there. And as we rotate clockwise, we'll get the arch of the aorta. And as we rotate slightly more clockwise and thumb down on the transducer in advance, you can get that view of the aortic arch, pulmonary artery, and AP window, which I was having there a second. Now I have the great vessels coming off the aorta, and I'll skip the rest of this. Sometimes you can see thyroid if you look carefully. I have on 2 occasions now found parathyroid adenomas in the setting of a patient with unexplained pancreatitis. So that's a normal, about a 6-minute exam, did a complete examination of the abdomen. Again, if you review that, we've looked at pancreatic head, body, tail completely. We've looked at left adrenal, spleen, kidney, mesenteric vessels, liver. The gallbladder was absent in this patient, so we didn't see the gallbladder. And looked at the mediastinum. We looked at all mediastinal stages for lymphadenopathy and didn't see anything. And you can really do a pretty complete exam in addition to a focused exam fairly expeditiously. So now I'll move on and talk about lumps and bumps. This is my lumps and bumps talk, which I've used many times over the years. But we see this a lot endoscopically, where we'll see a bump of something protruding into the lumen. We don't know if it's intramural lesion or extrinsic compression, or we'll see thickened folds in the stomach. And endoscopic ultrasound can be very useful in helping to differentiate the etiologies of these. I like to use the word subepithelial tumor rather than submucosal tumor. Submucosal tumor implies that the lesion is in the submucosal layer, which again, the majority of these really aren't. But this is defined as a protrusion into the bowel lumen covered by endoscopically normal mucosa. It can be a lesion associated with the gut wall. Extrinsic compression I consider to be a separate entity, and we'll talk about that in a little bit later. These can have a wide range of clinical behavior. Some of these are non-neoplastic, some are benign, some premalignant, some malignant. And again, I avoid that use of a submucosal tumor. So why is EUS useful for this? Well, EUS, one of the very early applications of endoscopic ultrasound was just examining the wall layers of the stomach and looking at these nodules. So a lot of the initial data on endoscopic ultrasound was looking at intramural, submucosal, subepithelial tumors, obtaining a differential diagnosis. And you can see on the left, you have a histologic image which correlates to these wall layers with the cartoon in the middle showing that you have 5 layers. The first layer, again, is kind of the acoustic interface between the water-filled stomach and the surface. Maybe a few cell layers thicken the mucosa, but not all of the mucosa. Layer 2 is called the deep mucosa. That includes lamina propria, muscularis mucosa. Layer 3, submucosa, which is bright white because it's fat density. Layer 4, muscularis propria. Sometimes you can see this in a series of 3 layers corresponding to the inner circular and outer longitudinal layers. And then layer 4, if there is a serosa, is the serosa. Again, the esophagus doesn't have serosa, the stomach does. In the esophagus, you just see surrounding fat or adventitia. And if we find these lesions in the wall of the stomach, often we can identify what I call a fusiform transition zone, where you can see the mass arising from or attaching to one of these layers. And here on the right, you see a hypoechoic mass with a transition point to the muscularis propria, which implies that it is of a muscular origin in the muscularis propria. I will counsel to be careful about something I call the floppy tumor effect, which is if you have a tumor that's protruding into the lumen, you can easily misinterpret what layer that's attached to. And I use this as an example. This is a kind of an irregularly shaped polypoid mass. And you can see if I image it in a plane perpendicular to where that dotted dashed line is and flip the image on end, like I had done earlier with some of the anatomic descriptions, you can see I can make it appear that this nodule is just floating in space and not even attached to the wall. And so to determine the layer of origin, it's important to scan carefully back and forth over the lesion and really look for that fusiform transition zone if possible to determine where it arises. In addition to looking for layer of origin, we want to look for the echogenicity of the lesion. Is it hyperechoic, which would suggest in most cases a fatty etiology, but not always. And I'll show an example of one where that's wrong. Is it hypoechoic or is it anechoic? And then if we combine these characteristics, so we combine the presence of a parent subepithelial lesion with the layer of origin and with the underlying echogenicity, sometimes that by itself can be diagnosed. And we'll talk about this now based on the layer of origin. Lesions that arise in layer 2 are relatively uncommon. They're nearly always hypoechoic. I have an example of a hyperechoic lesion. And the differential diagnosis is primarily leiomyoma arising from the muscularis mucosa. Granular cell tumors can arise in this layer. Carcinoids can arise in this layer. And this example that I'm showing here, this bright white lesion, is actually a Brunner's gland adenoma. This is one of these humbling cases that I had over the years. This is my chief of surgery's mother. When I just started in practice, and I did an endoscopic ultrasound and saw this lesion, I said, aha, it must be a lipoma, it's bright white. But it looks easy enough to take out because it's only attached to the deep mucosa. So I did a snare excision of it, and it came back as a Brunner's gland adenoma. So it's just an example of caution that sometimes you can be overly confident about a diagnosis without a tissue diagnosis. One of the important aspects of seeing something in layer 2 is that it can tell you that this lesion is amenable to either tunnel biopsy, forceps, snare excision, or EMR. Layer 3, we have hyperechoic lesions, can be lipomas, Brunner's gland adenomas, or occasionally lymphomas. Lymphomas, I've found, can have a variety of appearances, and there really is no obvious characteristic appearance of a lymphoma. Hypoechoic lesions in layer 3 can be carcinoids or pancreatic rests, and then a variety of uncommon lesions. In layer 4, these are usually GISTs, gastrointestinal stromal tumors, sometimes leiomyomas. Hyperechoic lesions in layer 4 can be lymphomas, neurogenic tumors, or metastases, but relatively uncommon. I see someone raised a hand. Let me address questions at the end. I'm happy to address Dr. Muhammad's question at the end if that's possible. Anechoic lesions tend to be fluid collections. These can be duplication cysts, retention cysts, or vessels. Cysts are differentiated from vessels by assessing the response to movement of the scope. Cysts will wink in and out of the image, whereas vessels stay in view as tubular structures like we saw in that video demonstration. Extrinsic compression can present as a subepithelial tumor, and I'll show some examples of that in a little bit. The most common examples of extrinsic compression that I encounter in my practice are gallbladder, spleen, splenic vessels, particularly the splenic artery arising from the celiac trunk is often misinterpreted as a submucosal tumor. Sometimes we see pseudocysts protruding in the stomach. Occasionally I've seen patients with a prominent aortic arch referred for a submucosal tumor or a variety of other less common things. Tissue sampling is very helpful, I think, in endoscopic ultrasound evaluation of submucosal tumors or subepithelial tumors. You can get an adequate specimen in at least 80% of the cases, particularly now with the newer needles. This compares to about a 40% yield with tunnel or well biopsies using large forceps. Importantly, nowadays, this allows for immunohistochemistry to assess for things like c-KIT and other tumor markers that can help us significantly narrow our differential diagnosis. It cannot by itself determine the mitotic rate for GIST, and so we don't generally use this to assess risk of malignancy and the need for surgical excision, but it can do DNA analysis now and assess for sensitivity to specific chemotherapeutic agents, which we do frequently. So talking about specific lesions, generic category is mesenchymal tumors. This can include things like GIST, leiomyoma, ganglioneuromas, Schwann cell tumors, mesenchymal tumors. And again, in the room, when we do the biopsy, what we see are spindle cells with these cigar-shaped nuclei. By itself, that's not enough. We need to send a cell block or core biopsies of this material for additional immunohistochemistry. And then by staining for c-KIT, smooth muscle actin, S100, we can identify which of the mesenchymal tumors this would be. Just stain positive for c-KIT, ganglioneuromas or neurogenic tumors stain positively for S100, and leiomyomas are generally negative for those, but positive for smooth muscle actin. This is just an example of a GIST. And I use this to point out that with large tumors, it can be difficult to identify the layer of origin. And tissue diagnosis really is necessary to clarify which of the two this is. And again, we talked before about differentiating mesenchymal tumors based on staining. I'll skip over that. Lipomas are hyperechoic lesions within the submucosal layer. They again can have a pillow sign. This is an example of a symptomatic lipoma. So it's an older video, but this is about the only person I've ever seen that was having symptoms from a lipoma. And their tumor was prolapsing through the pylorus and causing intermittent obstruction. And so this was removed. But again, that's very uncommon. Most lipomas we just leave alone. There are scattered cases of liposarcoma, but there's been no reports to my knowledge to determine when we should be suspecting that or what sonographic features would predict malignancy. I think they're rare enough that there just isn't data on that. This is a pancreatic rest, which again is a benign lesion characteristically located 1 or 2 centimeters proximal to the pylorus on the greater curvature. They have a variety of image appearances on ultrasound. In this case, I use this example because you can actually see small ducts within the pancreas tissue here. You see little ductal tissues. These tend to be hypoechoic granular type lesions on endoscopic ultrasound, which can splay between multiple layers involving layer 2, layer 3, and layer 4. They can be difficult to get adequate tissue from. I have had one patient get pancreatitis in the pancreatic rest with a biopsy. And typically, if you see this kind of centrally umbilicated lesion in that characteristic location near the pylorus, we don't need to get tissue, but it is possible. Carcinoids, again, often in the fundus and proximal body. This is an example of a carcinoid that was in the submucosal layer that we were able to remove with endoscopic mucosal resection. These are pretty uncommon, about 0.3% of gastric tumors. Again, getting into optimal management of carcinoid would take probably half an hour, so I won't get into that. I would say, however, that it should make you think if you're seeing multiple gastric carcinoids about whether they have hypergastrinemia, whether they have atrophic gastritis, whether they have pernicious anemia. Duplication foregut cysts or duplication cysts and foregut cysts are relatively uncommon. These are congenital lesions. They're generally benign. There's a lot of disagreement in the literature about whether they should be resected or not. I generally don't resect these unless they have symptoms related to that. There are some authors that propose that they've seen a case of this that developed malignancy in it, and therefore they should all be resected. But to me, that's like making the argument that you can get esophageal cancer, so everyone should have their esophagus resected. It's relatively uncommon to have complications with these, but it can present with pain, dysphagia, or chronic cough, in which case we resect them. If you can tell what they are by ultrasound imaging, we leave them alone. Sometimes, particularly in the stomach, you can see that they have distinct wall layers identical to the wall layers of the stomach, with a discrete hypoechoic muscular layer and an inner layer of epithelium. If you do sample them, they tend to have thick gelatinous mucoid material, and sometimes in the mediastinum you can see respiratory epithelium if they're bronchogenic. This is the only example I have endoscopically of one, and it's very old. I apologize for the old video quality, but again, this is a patient who presented with dysphagia. They have a small lesion in the esophagus covered by normal mucosa. And on the ultrasound, you'll see at the lower right-hand side of the image here, if you can see my arrow, that there's a thickening of the esophageal wall, and it has this kind of speckled starry sky appearance, which is really fairly characteristic of these mucin-containing duplication cysts. And again, this patient, I did do a needle biopsy of and just got a thick pellet of gelatin that came out of it. Moving on to thickened gastric folds. There's a significant differential diagnosis with this. And again, I think the thing we get most worried about is whether it's linitis plastica in the stomach, but it can also be disorders such as Menetrier's disease, Zollinger-Ellison, malt lymphoma, this parasitic disorder that I've never seen, apparently related to sushi. It's supposedly very dramatic. You see parasites sticking their heads out of little pits in the stomach, but again, I've never seen that. Gastric varices, if they're just thick folds but otherwise look normal, it's benign hyperrugosity. And then granulomatous disease can have this appearance too. These are some examples of linitis plastica, and again, just very thickened, doughy, non-distensible gastric folds within the stomach. Often have an endoscopy somewhere else prior to coming to see me, and it's read as gastritis. The biopsies come back as normal mucosa because it is covered by normal mucosa, very resistant to getting tissue sampling from the actual malignancy. The clues to this is that they're having symptoms out of proportion to just gastritis. And again, when you're in there endoscopically, the stomach just does not adequately distend with air. This is an example of a linear array EUS of linitis plastica, and you can see marked thickening of the gastric wall, which is easier to see in this image because there's ascites on the deep surface. This is a case where the gastric wall measured about 13 millimeters, which is actually the average size of the gastric wall thickening. It can be this hypoechoic tissue that kind of percolates through the submucosal space in an irregular fashion, sometimes invades the muscularis propria, sometimes does not. You can get a tissue diagnosis with needle aspirate of this, particularly with the newer biopsy type needles. In this particular case, we had done multiple forceps biopsies, needle aspirations, not gotten a diagnosis, and then eventually sampled the ascites, which had positive cytology for adenocarcinoma. This is the only case of Menetrier's disease I've seen with endoscopic ultrasound. I've seen a couple of other cases that had been diagnosed elsewhere, but what you see is really dramatic hypoechoic thickening of layer 2. In this case, I did a suction mucosal resection of the tissue to try to get a biopsy because it had multiple previous non-diagnostic forceps biopsies. And what you see are these corkscrew cystically dilated gastric glands, but characteristically cystic spaces at the deep region of the mucosal resection in the submucosa or deep mucosa. And that's the characteristic finding is these cystic spaces deep in the mucosa or submucosa. This can be associated with cytomegalovirus in children and adults. It's usually not. And it does have a risk of gastric cancer, but it's unclear if there's a role for screening. They often present with protein losing enteropathy. Zollinger-Ellison can cause the same appearance with thickened gastric folds. I've never personally seen that. And by reports, the endoscopy is indistinguishable from Menetrier's disease. It is a much more common disease, not that Zollinger-Ellison is really common, but Menetrier's is vanishingly rare. The pathology should show foveolar hyperplasia without cysts. The EUS, to my knowledge, has not been described, but presumably it's similar to Menetrier's. The key with Zollinger-Ellison syndrome, again, is to look for the primary mass, which again, 2/3 of the time is in the pancreas and 1/3 of the time in the duodenal wall. This is an example of gastric lymphoma. Just to show you, this is really dramatic thickening of the entire circumference of the gastric wall, hypoechoic splaying of the layers, and in this case with a bulky tumor on the outside of the wall. This seems to be less common nowadays. I haven't seen many gastric lymphoma cases in the past several years. And gastric varices, if you see on the upper left-hand side of the image, these are just tubular structures within the folds that you can identify Doppler signal with them. The grab bag diagnosis, if you're not finding anything, is benign hyperrugosity. And this just shows prominent folds. But eventually, when you get the stomach adequately distended with fluid, they can all be distended enough to show that they're just redundant folds of otherwise normal tissue, which when adequately distended has a normal thickness. You may have very minimal thickening of layers 2 and layer 3, and then the tissue diagnosis is normal. And this is really of no clinical significance, but often seen as an incidental finding on CT scan, which leads to the exam. Again, there are some rare causes of thick folds, but I have not seen cases present with this or have good examples of them. Granulomatous disease, histoplasmosis, which is common in our part of the country, but relatively uncommon, secondary syphilis, sarcoidosis, eosinophilic gastroenteritis. All of those things can cause thick-fold gastropathies, but again, they're exceedingly rare, typically diagnosed either by forceps biopsy or clinical history. So I wanted to show a couple of cases. This is a case of a 43-year-old male who presented with dyspepsia and had an endoscopy by one of my colleagues that showed a deformity in the antrum, kind of a submucosal subepithelial deformity in the antrum, and the EGD is shown here. This is a radial and linear ultrasound of this patient, and you can see with the radial exam, you're seeing some circular structure here near the liver, adjacent to the duodenum, and with the linear exam, you see that it has this kind of sickle-shaped layering debris within it. And this was the gallbladder. So this is a patient who had an obstructing cystic duct stone, had had chronic cholecystitis, had been having pain for several months, and we just sent him for a cholecystectomy and his symptoms resolved. This is another relatively uncommon disorder. This is a patient who presented with what was thought possibly varices, but they were unclear if this was varices. Patient was presenting with dysphagia, which didn't really fit with varices. And therefore, prior to doing treatment on this, the patient was sent for an endoscopic ultrasound. This endoscopic ultrasound was done with a kind of a prototype radial scope from Pentax. So the scope, that's why there's an image missing from the top. But here you see kind of diffuse circumferential thickening of the esophageal wall, loss of wall layers. At the very beginning of the image, there was some tissue extending outside of the wall. In this case, clearly not varices. We did a needle biopsy of this, and this was actually esophageal linitis plastica with metastatic transitional cell carcinoma of the bladder. And finally, this is a patient, an elderly woman with dysphagia, refractory to dilation. You can see the barium study on the left, which raised question of achalasia. Had an endoscopy, which they said it was very rigid, but seemed more than just localized at the gastroesophageal junction. Forceps biopsies were negative. Endoscopic ultrasound here showed a hypoechoic mass eccentrically arising from the esophageal wall with these kind of jagged, irregular outer margins. And a needle biopsy was performed, and this was metastatic lobular breast cancer that was 15 years after the previous mastectomy for breast cancer. So again, just to point out that I do think there is reason to do needle biopsies on these lesions. Don't jump to the conclusion that you know what the diagnosis is, and sometimes you find unexpected findings. I'll briefly talk now about complications of endoscopic ultrasound. I don't think you've had a discussion of this as of yet. I will not address complications of interventional EUS. That really is a whole separate topic. I will point out, however, that there's really limited literature on kind of a systematic analysis of complications of EUS, and so much of this is based on personal opinion. Clearly, there's a risk of aspiration pneumonia with endoscopic ultrasound. The actual rate of this is undefined. There are several reasons why this can happen, and clearly one of the issues is that often when we're doing radial exams, we put some water in the stomach, and that can reflux and lead to aspiration. In addition, the presence of deep sedation as opposed to general anesthesia will clearly affect the risk. General anesthesia provides airway control. Nowadays, if I have a complicated case where I know I need to fill the stomach with water, I will generally prefer doing this under general anesthesia just to have adequate airway control. There's likely a higher risk in the setting of luminal obstruction. Clearly, if we do an endoscopy and the stomach is full of food, that will increase the risk of aspiration. Neurologic deficits, stroke, airway, people having difficulty controlling their airway obviously increases the risk of aspiration. It would seem to me logical that the presence of a necrotic esophageal mass would also increase that risk, although that's not been shown. Methods of avoiding aspiration. Again, I avoid routine water installation unless I absolutely need to, only when I'm trying to image the bowel wall and only after I've completed the duodenal exam. I find that if we put fluid in the stomach and then try to go through the pylorus, it often induces retching in a patient who's not under general anesthesia. And so I try to complete my duodenal exam first, come back in the stomach, then fill the stomach with water if I need to. Whenever I fill the stomach with water, I place the patient in reverse Trendelenburg, and I always make sure that we have oral suction immediately available. The risk of perforation with endoscopic ultrasound is estimated at somewhere about 1 in 500 to 1 in 1,000, which is higher than I will admit I often quote to patients. There are several issues that have been proposed over the years, but it's really unclear to me that the type of endoscope causes a higher risk of perforation. I think it's probably more related to experience. Some clinicians are much more comfortable with radial exams. Some are much more comfortable with linear. And I think once you get comfortable with these, they're done safely. I hear people intermittently complaining that one scope is more dangerous, and I think that's not really justified. Clearly, in the setting of a stenotic esophageal cancer, there's an increased risk of perforation. To complete an exam with a standard linear EUS scope, you need to dilate to 15 millimeters, and it's unclear that this is always warranted. With dilation, the literature would suggest that the risk is up to about 1%. And it's probably higher if the lesion is metastatic or non-circumferential, because then you're dilating and exerting the force against a solid tumor, but the opposite wall of the esophagus is thin-walled, and the area of least resistance is to tear the thin wall rather than to stretch the tumor. What I do rather than doing dilation, if I feel that I need to get through a stenotic esophageal cancer, which is at times necessary. People have celiac lymph nodes, lesions in the left lobe of the liver, gastrohepatic lymphadenopathy. I'll just switch and use an endobronchial ultrasound scope, which is shown on the lower right. That's 6 millimeters in diameter as opposed to 15 with the standard linear scopes. And then that will allow us to get through the tumor in almost every case. Let us look at the proximal stomach, the left lobe of the liver, and the celiac and gastrohepatic ligament regions, left adrenal if we need to, and get a biopsy there. And plus we can do sonographic staging of the entire length of the tumor. Duodenal perforation occurs, and I'll focus on this in a little bit in addition. Duodenal perforation often can be due to a stenotic tumor or the presence of a diverticulum, which is previously unknown. Again, you should be highly concerned about this if patients are presenting with new abdominal pain after the procedure with crepitus, free air on exam. Typically the response would be to get a CT scan. Abdominal x-ray by itself may not pick this up because often the free air is in the retroperitoneum, the gas is extraluminal in the retroperitoneum surrounding the kidney, but not freely in the peritoneal space. How do we avoid this? Well, I don't always do a diagnostic endoscopy, but if I'm running into any significant difficulty getting from the pylorus to the second portion of the duodenum, I will go with the diagnostic endoscope, make sure there's no luminal obstruction, make sure there's not a large periambulary diverticulum. We need to be taking care with esophageal cancer, as I talked about before, and again, not dilate if there's a non-circumferential or non-esophageal primary. And again, take especially careful examinations in patients with altered surgical anatomy. If I know that there's a lesion I need to get to that requires going down surgical limbs, I typically will schedule them with fluoroscopic guidance. I will definitely do a diagnostic endoscopy first. I don't have ability to do end viewing endoscopic ultrasound. We don't have that scope, but that's another option if it's available. And if it's an intramural lesion, you may be able to get there with an endoscope and use a mini probe and not need to get one of these bulkier endoscopic ultrasound scopes down the lumen. Additional things that we always need to keep in mind that we often forget to talk about with avoiding perforation is if you're having difficulty, you should stop yourself and ask, is it justified that I'm continuing to attempt this exam? Should I just stop? Do I need to do this? Is there another way to get this answer? Would it be better to do this on another day, have different anesthesia, have the patient positioned differently? Should I get another endoscopist who has more experience to try? Should I do it under general anesthesia? Should I reschedule it with fluoroscopy? All those things should be crossing your mind if you're having difficulty with the exam. Finally, I won't dwell on this, but I think one of the other complications of endoscopic ultrasound is inaccurate interpretation. And we have absolutely no way to assess this. but there are all sorts of things that we can do wrong by doing the exam. And to me, a missed malignancy is a complication of endoscopic ultrasound, because then you're going to delay treatment or falsely reassure the patient. We can overstage a tumor and eliminate a chance for cure. We can understage the tumor and lead to an otherwise avoidable surgical exploration, or we can label somebody with something they don't have, which in our country often happens with chronic pancreatitis. Methods for avoiding inadequate inaccurate interpretation include what you're doing now, which is going to courses, getting educational material, reviewing your pathology with pathologists, review your staging results with the surgeons, go through the imaging carefully and compare them. Mortality rate has been associated or estimated about 1 in 3,000. And there was an interesting study out of Israel in 2005 where they reviewed all of the endoscopic ultrasound cases that were performed in Israel. And they found an overall mortality rate of 1 in 3,000. And these were almost all related to duodenal perforation. I'm going to skip over complications of needle aspiration and pancreatitis, and I leave some time for talks or for questions here. So, but in summary, EUS is relatively safe. Most of the literature is retrospective. As we use this more and we get more and more prospective studies, we're going to find that complications are more common than we used to think. The only way to completely avoid complications is to not do the test, and sometimes that may be the appropriate decision. And studies defining adequate risk factors are further needed. Thank you for your time. So there was a question. Let me see if I can get to that now. I lost.
Thank you, Shawn. I can maybe read off. I think Dr. Ghias and some other colleagues, Dr. Tahini, were also answering the questions. But one of the questions that came up was, in terms of evaluation of the bile duct, what's your experience with evaluation of the bile duct from the stomach versus the duodenum? And what's your approach?
Sure. So one of the things I always try to teach my fellows is to try to think of multiple ways to view the same structure. And I think this becomes more and more valuable when you run into patients with altered anatomy. Particularly, we see people with gastric bypass, and there are ways to look at the bile duct with the gastric bypass, but it's just not where you normally think. What I typically do when I try to look at the bile duct in an average patient is I start at the papilla and I try to gradually pull back and torque counterclockwise and follow the bile duct from papilla up towards the liver. It's very common that when you get to within about 1 or 2 centimeters of the undersurface of the liver, you lose visualization because of air in the duodenum, or the scope falls back into the stomach. And then I'll go back, I'll make sure I'm fully into the stomach, advance back through the pylorus and keep the scope in a long position and look at the duodenal wall that's basically facing me endoscopically on the upper left-hand side of the image, push my balloon into that part of the duodenum and find the bile duct there. And usually I can follow it in a controlled manner from that point back up into the liver. If I have trouble from the papilla and I can't follow it even more than 1 centimeter or 2 from the papilla, that's my backup approach to looking at the bile duct. I honestly think that's the easier way to teach fellows how to follow the bile duct, is from the bulb. From the stomach, you can see it if you get a view where you see the superior mesenteric vein attaching into the portal confluence. In the notch deep to that, near where the uncinate process of the pancreas is, you can usually pick up the bile duct coming through the pancreas and then follow it from that point adjacent to the portal vein into the liver to see the rest of the way, which I find useful in people with altered surgical anatomy.
Okay, yeah, thanks. Excellent. I think for people who do EUS enough, they'll know that subtle difference of the antral/distal stomach view, where you have that confluence and then you can see the bile duct behind the confluence. Mm-hmm. And that's something I found in my training or my experience, that early on I couldn't pick that view up, but as time went on, I was able to identify that more reliably. Another question that came up, I think for the intents of this presentation, you summarized your exam within 6 minutes, but the question was, is overall 6 minutes a short duration for an exam?
Oh, absolutely. No, my point, so typically, just to point out my approach to an exam, if I think that I'm going to biopsy something, so there's a lot of things that factor into what I do first when I do my exam. And if a patient has a specific clinical issue, I go and try to look at that right away and address, do they have the problem that they sent me for, or that they sent them to me for several reasons. One is, if it's something I need to biopsy, we use rapid on-site cytologic interpretation at our hospital. And if I know I need to biopsy something, I want to get the pathology team on their way coming to my room to be able to help with that. So as soon as I find something that I'm going to biopsy, I call pathology. And then I start looking at the other things. And so then I'll look, so if it's a pancreas mass, can I find the pancreas mass? Call pathology. When I know they're on their way, then I look, is there a metastatic focus somewhere? I look at the liver, are there lymph nodes? Is there something else that I want to biopsy other than the pancreatic mass? But I focus on the issue at hand, and I make sure I get that done, so that if the patient has problems with anesthesia or is having problems with sedation, that I've at least answered the question they're there for. But always, when I feel like I'm done addressing the topic of the exam and the focus of the exam, I do a complete exam to make sure I've looked at everything else. Does that answer that question? And so this example that I show is an example. We used to get people frequently referred to assess for chronic pancreatitis in the setting of chronic abdominal pain. And they very commonly had completely normal exams. And this was an example of someone who was referred for chronic pancreatitis, who clearly did not have chronic pancreatitis. And you can assess that by looking at the pancreas in about 3 seconds. But then after that, it's, well, I need to do a complete exam. They're having pain. Do they have a common bile duct stone? Do they have adenopathy? Do they have a thickened gastric wall? And so that's an unusual example of a really quick, straightforward exam.
Yeah, I think from a training perspective, those normal exams are excellent for the trainees, because you quickly know you don't have to do much. And you can then spend 10, 15 minutes teaching the trainee actually how to do an exam. I remember that's how I learned a lot.
The best exams we have for fellows are we're one of the few places that does formal pancreatic function tests. And so we'll do secretin infusions and then measure duodenal aspirates every 15 minutes for 45 minutes. And I can be done with my EUS exam in 5 minutes in those patients, but then we have to be there. And we do all these under general anesthesia because they're chronic pain, chronic narcotic using patients that are hard to sedate. So then we've got 45 minutes for the fellow to kind of learn anatomy, and those are the best exams. Yeah.
Okay, very good. We have a couple more panelists who've joined. Dr. Mohammed Hassan from Florida and Orlando, and then Dr. Nadeem Tahami from University of Southampton in the UK. I don't know if they have any additional comments or questions, but I'd like to sort of welcome you both as well to comment.
Shawn, this is Mohammed. I'm from Orlando.
Hi.
Thank you so much for such an excellent presentation. And sorry, I was a little bit late in joining, but I think every time we hear expert like you, this always there's some learning point. So I totally agree what you've been saying about the exam. It's really. And that's what I tell my fellows too. Just make a habit. First, sometimes you have to do a focused exam, no question about that. So you can answer the question and then spend time. And I go step by step, same thing with the complete pancreas exam, mediastinum. Like my report usually always have 5 components. One is pancreas, then about the celiac axis, about the mediastinum, and all left adrenal as well. So if you have time, and in the beginning, it's never gonna be that you can do the exam in few minutes. Yes, you can if once you have done plenty. Once you have done it for a few years, maybe you can finish it in a few minutes. But every time you get a chance to do EUS, try to do a complete examination, and that way you don't miss anything. And unusual, even in Florida, we get a lot of these patients for abdominal pain evaluation, rule out chronic pancreatitis, and majority of the time they usually don't have this, but sometimes you can pick up something unusual which can explain their symptoms. So just make a habit of doing a complete exam on every time you can get a chance to do that.
It's great to see you, Mohammed. I'm glad you chimed in.
Shawn, thank you very much for a fantastic presentation. I just got a couple. To start off with the examination, I think what I tend to sort of recommend fellows when you start the examination just below the geogen, and you start examining the liver, it's always best to just have a look for any free fluid present, because if there isn't, you end up causing a complication, then at least you've documented it to the start of the procedure, whether there was an ascites or not. The second thing is in terms of, I think when you said in terms of interpretation of finding, so also quite important when a person has, or a fellow has an adequate examination, simple things, for example, looking at the appearances of a dorsal and the ventral pancreas and not ending up interpreting those normal configuration as a mass lesion. And the question that I have for you is, in terms of the EUS F&B associated pancreatitis, do you think, it may sound like a simple question, but is there any difference while you compare needling a lesion in uncinate compared to the other parts of the pancreas? Once again, thanks for your presentation.
Sure. So to me, the risk in sampling something in the uncinate process in particular, and again, for the interest of time, I skipped over some slides I had on that, but the key to reducing the risk of pancreatitis with the biopsy is paying attention to what you're going through to get there. And if you're biopsying something in the uncinate process, often your endoscope will be oriented in a situation where your major papilla is very close to where your biopsy channel is. And so you need to be very careful to visualize the major papilla endoscopically and sonographically, and make sure you're not going through the papilla with your needle. And I think that's one of the main risks with pancreatitis. The other risk is inadvertently going through the pancreatic duct with your needle. And so I always try to visualize the pancreatic duct no matter what region of the pancreas I'm sampling. And then I think the other risk factor for pancreatitis with FNA is using your elevator to adjust the angle of the needle through normal pancreas. And I think particularly with stiffer needles, you can fillet the pancreas by having your needle extended in the pancreas and using your elevator up and down. And I've definitely seen cases with pancreatitis from that, cases going through the papilla, cases going through the duct. Sometimes it's just, you can be as careful as you want, and it's something that's almost unavoidable. But to me, the risk in the uncinate is that you damage the papilla.
Yeah, and I think Nadim's point about the ventral versus dorsal and the ventral being mistaken as a mass is a valid one. I remember you used to tell me that during training that this can often be, misinterpreted as being a mass, but it's actually normal ventral.
Yeah, and I think that's where it's helpful to follow vascular structures and the duct through that area and see if they're getting distorted by that. And the margin of the ventral enlarge is almost always straight. It's a straight line, whereas the margin of a tumor is not typically straight. And if you can see the duct crossing that, or vascular structures crossing that border and not being distorted or changing caliber, that really tells you that it's ventral enlarge. The other area where you see artifact that you can misinterpret as a tumor is in the gallbladder fossa in a patient with a hyperechoic fatty liver. They often have a little lens-shaped area of fatty sparing in the gallbladder fossa that you can misinterpret as a tumor. And the same issue is, see if it's disrupting vascular structures through that area. The other thing I forgot to mention, but people focus a lot on linear exam, on stations and getting to a specific spot and getting a set photo of a structure. And I really de-emphasize that when I'm training. To me, a linear exam to me is analogous to doing a waltz. And it's a lot of gradual movement and sweeping and going back and forth over structures and seeing where they go. And it's a fluid, mobile exam rather than a rigid stage-based exam.
Question,
Totally
the
agree.
two questions from the audience. First, do you
Yeah.
use balloon in each and every case of linear examination? And secondly, how do you differentiate between hypertrophic gastric mucosa from Menetrier disease?
So the balloon, I do not routinely use the balloon. I will say I inflate the balloon minimally for most exams. I find it helpful, particularly, I think it serves as a little bit of a bumper to get around from the bulb into the second portion. But I don't think it's necessary. With most linear exams, when you're looking at something outside the bowel wall, you can suction the air out of the lumen to get it out of way. And I will use minimal water in the balloon to push into the wall if I'm having trouble getting air out, but I don't find the balloon mandatory. And if that's relevant, in times we'll go in and then the balloon leaks, or we find that there's air in the balloon that we didn't get out. And I'll typically just try to do the rest of the exam, not fixing that. And I'll come out and fix it if I need it, but it's not mandatory for most of the exam, I don't think. The atrophic gastritis, so endoscopically, they look very different. So again, atrophic gastritis, there's a complete loss of rugal folds. You can see through the mucosa and see increased vascularity in the wall, which looks almost like a normal colon wall when you see lots of submucosal vessels. And to diagnose atrophic gastritis, we typically get mapping biopsies. And then we have to very specifically tell the pathologist that we're looking for atrophic gastritis, because I think our pathologists in general are not really comfortable making that diagnosis, and unless we push them to think about it, they won't comment on it.
Let me rephrase my question. How do you differentiate between pathological gastric hypertrophy from a benign gastric hypertrophy?
Oh, so reactive gastritis, so acute H. pylori, those sorts of things can cause a little bit of thickening of the wall. They tend to be localized to layer 2. And not nearly as thick as you would see with Menetriers. I think the only way to be definitive about it is to get a deep biopsy, like I showed in the example of Menetriers, which is a cap biopsy. But you don't need that in most cases of just reactive gastropathy. So if I do an exam and it's reactive gastropathy, the deep mucosa may be 2 millimeters thick or something like that. Not that dramatic thickening that we saw in that ultrasound exam with Menetriers. And so in most cases, if there's a little bit of mild air.
It remains for me, Professor Shawn, to thank you for your wonderful presentation. It's, I know, early in the morning in Minnesota, and it was 6 in the morning that you had to wake up so early, and had to on Sunday.
We're all physicians.
I'm really thankful to my other colleagues, Mustafa Arai, Khalid Hassan, Nadeem Thiami, and all the colleagues here in Pakistan, and similarly my colleagues in Wilson Pharmaceutical for sparing time. See you next week, and next time it's going to be Bill Strictures, and Rohos is going to be a speaker. So once again, Professor Shawn, thank you very much, and I hope to see you sometime in Pakistan when the COVID issue is over. We'd love to have you here in Pakistan to have one-on-one interaction on patients and otherwise as well. You've shown us wonderful pictures of Minnesota, and I'm sure you're going to love the pictures of Pakistan as well. So thank you. Take care. Bye-bye.
Thank you very much.
Thank you. Bye-bye.
Thank you, sir. Thank you, sir.